Pancreatitis is divided into two forms: acute pancreatitis and chronic pancreatitis. Both of these forms are initiated by injuries that lead to autodigestion of the pancreatic tissue by its own enzymes. Under normal circumstances, pancreas has several mechanisms that protect it from self-digestion, including the following. Most digestive enzymes are synthesized as inactive proenzymes, also known as zymogens, which are packaged within secretory granules. Zymogen granules have an acidic pH and a low calcium level, which prevent premature activation of zymogens. Most proenzymes are activated by trypsin, which itself is activated by duodenyl enterokinase in the small intestine. Thus, intrapancreatic activation of proenzymes is normally minimal. Moreover, acinar and pancreatic ductal cells secrete trypsin inhibitors, which further limits intrapancreatic trypsin activity. So, pancreatitis occurs when these protective mechanisms are deranged or overwhelmed. Acute pancreatitis is characterized by reversible pancreatic parenchymal injury associated with inflammation. It can return back to normal after resolution of the episode. Acute pancreatitis is a relatively common condition. The annual incidence in Western countries is about 10 to 20 cases per 100,000 people. Gallstones and alcohol account for the vast majority of cases in Western countries. Acute pancreatitis ranges from mild and self-limiting to extremely severe disease. In severe disease, there is extensive pancreatic and peripancreatic necrosis, along with hemorrhage, which carries a high mortality rate. Now let's discuss about the etiology of acute pancreatitis. Most common causes of acute pancreatitis include the following: gallstones, alcohol. Following endoscopic retrograde cholangiopancreatography, which is a technique used to diagnose and treat conditions involving the liver, gallbladder, biliary system, and the pancreas. About 10% of pancreatitis cases are idiopathic, meaning that they do not have a clear etiology. Less common causes of acute pancreatitis include the following: trauma, infections with certain viruses, including mumps, HIV, adenovirus, and Coxsackie-B virus, pancreatic tumors, congenital pancreatic abnormalities such as pancreas divison, a condition that leads to formation of two main pancreatic ducts, metabolic abnormalities like hypercalcemia and hypertriglyceridemia, certain types of venom like scorpion sting and spider venom, and certain drugs, including the following: azathioprine and mercaptopurine, didanosine, estrogens, antibiotics like tetracycline, valproic acid, furosemide, sulfonamides, aminosalicylates, corticosteroids, metronidazole, and ACE inhibitors. In addition to these factors, hereditary factors also play a role in acute pancreatitis in certain individuals. Now let's discuss about the pathogenesis of acute pancreatitis. Acute pancreatitis results from inappropriate activation and release of pancreatic enzymes that destroy the pancreatic tissue and elicit an acute inflammatory response. But how this inappropriate activation of pancreatic enzymes occurs in acute pancreatitis is not completely understood. However, there is evidence that at least three major initiating events: pancreatic duct obstruction, primary acinar cell injury, and defective intracellular transport of proenzymes within acinar cells. Pancreatic duct obstruction is most commonly caused by gallstones and biliary sludge. Other causes of pancreatic duct obstruction include pancreatic cancer, cholelococele, or congenital cystic dilation of the common bile duct, parasites such as Ascaris lumbricoides, and pancreas divison. Whatever the cause, obstruction leads to accumulation of enzyme-rich fluid in the pancreatic interstitial tissue, which raises intrapancreatic ductal pressure. Unlike other enzymes, lipase is produced in its active form. Therefore, accumulation of lipase leads to local fat necrosis and adipocyte death. This will stimulate myofibroblasts and leukocytes to secrete pro-inflammatory cytokines, which will result in inflammation and edema, which compromise the local blood flow, leading to vascular insufficiency and ischemic injury to acinar cells, causing release and activation of pancreatic enzymes. Primary acinar cell injury can be caused by many factors, including oxidative stress and increased calcium flux, which causes activation of zymogens. Whatever the cause, primary acinar cell injury leads to release and activation of zymogens, causing inflammation and autodigestion of the pancreatic tissue. Defective intracellular transport of proenzymes within acinar cells is seen in animal models with acute pancreatitis. In normal acinar cells, digestive enzymes and lysosomal hydrolases are transported in separate pathways. However, in pancreatitis, some hydrolases and digestive enzymes are transported together, leading to activation of those enzymes. Alcohol consumption may cause acute pancreatitis through all of these mechanisms. Alcohol transiently increases the contraction of sphincter avati, leading to transient obstruction. And chronic alcohol ingestion results in the secretion of protein-rich pancreatic fluid that leads to deposition of protein plugs and obstruction of small pancreatic ducts. In addition, alcohol has a direct toxic effect on acinar cells. Alcohol-induced oxidative stress may generate free radicals within acinar cells, leading to membrane lipid oxidation. Oxidative stress also promotes the fusion of zymogen granules with lysosomes and mitochondrial damage, which increases intracellular calcium levels, leading to inappropriate activation of zymogens. However, it is important to note that most drinkers never develop pancreatitis during their lifetime. Thus, key aspects of the pathophysiology of alcohol-induced pancreatitis remain unexplained. This image is from the Robbins textbook of pathology. It is a summary of what we have discussed in the pathogenesis part. You can pause the video and go through it before we proceed into the next section. Now let's see what are the morphologic features in acute pancreatitis. The morphology of acute pancreatitis ranges from mild inflammation and edema to extensive necrosis and hemorrhage. Basic alterations are microvascular leak and edema, fat necrosis, acute inflammation, destruction of pancreatic parenchyma, and destruction of blood vessels and interstitial hemorrhage. In the milder form, acute interstitial pancreatitis, histologic alterations are limited to mild inflammation and interstitial edema, and focal areas of fat necrosis in the pancreas and peripancreatic fat. Released fatty acids may combine with calcium to form insoluble salts. In the more severe form, acute necrotizing pancreatitis, there is necrosis of acinar and ductal tissues, as well as the islets of Langerhans. Vascular injury can lead to hemorrhage. Macroscopically, the pancreatic substance is red-black and contains interspersed foci of chalky fat necrosis. In the most severe form, acute hemorrhagic pancreatitis, there is extensive parenchymal necrosis, accompanied by hemorrhage within the substance of the gland. Now let's discuss about the clinical features of acute pancreatitis. Upper abdominal pain is the cardinal feature in acute pancreatitis. The pain usually begins in the epigastric region. Acute pancreatitis is a differential diagnosis in any patient with upper abdominal pain. Abdominal pain is often accompanied by nausea and vomiting. As inflammation spreads throughout the peritoneal cavity, the pain becomes more intense. Involvement of the retroperitoneum may lead to back pain. And patient may give a history of previous similar episodes. Physical examination may reveal upper abdominal tenderness. In severe disease, patient will have tachycardia and hypotension, along with oliguria, widespread tenderness and guarding, and reduced or absent bowel sounds. Specific clinical signs that support a diagnosis of severe necrotizing pancreatitis include periumbilical bruising, or Cullen's sign, and flank bruising, or Gray-Turner's sign. Now let's discuss about the diagnosis of acute pancreatitis. Blood tests and imaging tests are the mainstay of diagnosis. Serum amylase is an extremely sensitive test if it is 3 times more the normal limit. However, other conditions that increase serum amylase should be excluded. These include upper gastrointestinal perforation, biliary peritonitis, and intestinal infarction. In addition to serum amylase, urinary amylase is also elevated in acute pancreatitis. Serum lipase is also raised in acute pancreatitis and remains elevated for a longer period of time than amylase. However, the accuracy of serum lipase is not significantly greater than amylase. CRP level is important in assessing the disease severity and prognosis. Other baseline investigations include a full blood count, serum creatinine and electrolytes, blood glucose, arterial blood gas analysis, and liver biochemistry. Imaging tests include an erect chest X-ray to exclude gastroduodenal perforation. A supine X-ray may reveal gallstones and pancreatic calcification. Abdominal ultrasound scan is important to identify possible biliary causes for pancreatitis, such as gallstones. It also detects pancreatic swelling and necrosis. In severe pancreatitis, the pancreas may be difficult to be identified due to the gas-filled bowel loops. MRI is useful in assessing the degree of pancreatic damage. It also identifies gallstones within the biliary tree and helps differentiate between solid and liquid inflammatory masses. Endoscopic retrograde cholangiopancreatography is used as a treatment measure to remove bile duct stones in selected cases of gallstone-related pancreatitis. Finally, let's come to the treatment of acute pancreatitis. Early fluid losses in acute pancreatitis may be large and require intravenous fluid administration. Urinary catheterization is essential to monitor the circulatory volume and to assess the renal function. Arterial and central venous catheterization may be necessary to facilitate close monitoring of hemodynamic status and to permit repeated sampling of arterial blood gases. Nasogastric suction is essential to prevent abdominal distension and vomitus in order to prevent aspiration pneumonia. In addition, prophylactic antibiotics and analgesics such as tramadol are also given. Low molecular weight heparin should be given for prophylaxis of deep vein thrombosis. Feeding of a patient with acute pancreatitis is usually by nasogastric administration of food. However, some people may not tolerate nasogastric feeding. For these patients, post-caloric feeding is indicated. Total parenteral nutrition is not indicated for the patients with acute pancreatitis due to the high risk of infection. Okay. That is all I wish to discuss in this video. Hope it made sense. If you have any question or doubt regarding this topic, feel free to post them in the comment section. Thanks for watching. See you soon in the next video.